Hello, everyone, and welcome to our inaugural episode of Beyond the Diagnosis, a podcast started through the Florida State University College of Medicine's Gold Humanism Honor Society. My name is Richard Wu.
And my name is Edward Cordy.
And we'll be your hosts throughout this mini-series we have for you all to kick off the podcast.
Yeah, and I mean, maybe we'll have some other, guest hosts, right, Richard? Some other people might help us.
We have a lot of great guest hosts in store for you guys.
Okay, good. Well, we should probably start off by telling you all a little bit about us. So, like I said, I'm Edward. I'm a fourth-year medical student at FSU, and I'm applying to residencies in combined internal medicine pediatrics.
And my name is Richard Wu. I'm a rising fourth-year medical student, also at Florida State University. I'm taking a little bit of a detour right now to pursue an MPH, but I will be applying to ENT when I return.
Yeah, so that's something that Richard and I have in common, that we both have a big interest in public health. And I took time to do an MPH after third year as well. Yeah, and we had a great first episode, didn't you think, Richard?
Yeah, I think we really touched on a lot of key points and really kind of delved into why we started this podcast in the first place.
Yeah, Dr. Brown Speights spoke with us about the interaction between racism and health and some of the important conversations and also actions that we need to be taking to move towards more equitable health in the United States.
And yeah, I definitely agree, especially students. I just think that the conversation that we had was so important to empower us to actually make concrete differences within our own communities. So with all this talk about our guests, I think it's about time we do a formal introduction. Do you want to do the honors?
Yeah, absolutely. So Joedrecka Brown Speights, MD, is professor and chair of the Department of Family Medicine and Rural Health at the Florida State University College of Medicine. She is a fellow of the American Academy of Family Physicians and a fellowship trained in maternal child health. She's the 2018 recipient of the Dr. Martin Luther King Jr. Distinguished Service Award by the Florida State University. Her experiences include serving as the medical director of the National Community Center of Excellence in Women's Health, Office of Women's Health, Department of Health and Human Services, at the Turley Family Health Center, where she practiced full scope family medicine, including operative obstetrics and global health. She completed her medical training at Emory University of Medicine, School of Medicine, before completing her residency at St. Vincent's Family Medicine Residency in Jacksonville, Florida. She is a 2017 inaugural fellow at the George Washington University Leaders for Health Equity and International Fellowship, now Atlantic Fellows for Health Equity. Her interests include promotion of health equity, especially maternal child health equity, through community engaged research, clinical care, advocacy, and education. She's also focused on faculty vitality, wellness promotion, and empowerment of women and girls. She enjoys spending time with her husband, Gregory, and family, and vacation traveling adventures. Wow, she's very accomplished, and I'm just glad that we got a chance to talk to her. Let's get to it.
Perfect.
All right, so Dr. Brown Speights, we'd just like to say thank you so much for being our first ever guest on Beyond the Diagnosis, and welcome.
Thank you so much. I'm super duper excited. Thanks for having me.
Yeah, so just to kind of get to know you a little bit better, I know we just kind of went through an intro, but if you were to introduce yourself at, say, a party, what are some ways that you would introduce yourself?
I'd say, hey, what's up? I'm Joe. And I'd probably mention, my husband, Gregory, who I love dearly. And, it sometimes comes up in a casual atmosphere that I'm a family physician. That's super duper important to me as well. And, my love for family and actually my faith. Those are the big three things I would say would come up at a casual conversation.
Fantastic. So you're a family physician. You're one of our faculty at FSU College of Medicine. and you're definitely, in the leadership of the College of Medicine. And one question I really like to ask very successful researchers and people in general is, what is a life hack? Sometimes people will tell me, oh, I always wake up at 4:45 and I do this or that. But what's a life hack that you've used?
Yeah, that's a great question. So I am one of those people. I don't typically get out of the bed at 4:45, but I wake up anywhere between like 4:30 and 6 usually, usually around 5 o'clock or 5:30ish. And every morning, almost every single morning, my husband and I pray at 6 o'clock together. And I think that even before I got married, just really waking up and having like that morning devotion time, or just time to kind of reflect and clear the mind and pray and things like that, that has been something that's been consistent since before med school. And it'll probably be with me for the rest of my life. So I do that. I'm an early bird. My juices get going pretty early, get everything cleared out. And then usually, depending on the day, I go for like a walk run after that.
Wow. That's fantastic. I definitely envy that.
Yeah, I should probably start doing that myself. So another question that we wanted to ask you, Dr. Brown Speights, was, we know about all of your successes and, what's brought you to this point, but could you tell us about a time that maybe you experienced a failure and what you ended up learning from that?
Yeah, so that's a hard question, actually, because I'm such an optimist and I just try to like move past the failures, and I do try to learn from them in that kind of way, but I don't always record them. But when I was thinking back, I think there's been times in my life where maybe, and this is earlier on, I hopefully have learned from this now, but sometimes when you have interactions with people and they interact with you a certain way, you can make a certain assumption about that interaction, like they don't like me, or they're mean, or they're rude, or they're whatever the blank is, right? And I've learned over time that you can't have that assumption. You have to really assume that people are coming from a good place. And I think I've also been shaped by like just the trauma-informed approach and trauma-informed care approach, which is, not asking people like what's wrong with you or wondering what's the problem, but really thinking about maybe like what happened to them. So just coming to the situation or to a relationship or to an interaction with someone with an open mind and thinking, like just assume the best about that person and go from there. I think that always, leads us to a much better place than assuming something negative or something bad. So I would say, there's been times where maybe I assumed, or just because of how someone interacted with me or how I've had that kind of interaction unfold in another relationship, that the person was coming from a negative place, and later realized, they weren't coming from a negative place. They had a bad day. They had something major happen to them, or, they're dealing with a crisis, or, they could just be cranky, but just assuming the good about other people, I think really is just a great way to approach interpersonal interactions with people.
That's awesome. I mean, I think that's going to be so useful to us moving forward as clinicians too. Mm-hmm. So a couple more kind of get to know you questions. Is there a book that I know medical students, trainees don't always have a ton of time to read, but sometimes we do? And what would you recommend of a book that we should read?
Yeah, I hate having to pick like one thing,
Oh, go for it. If you have multiple, no problem.
No, I don't really have like super duper long list. I do like to read, and I would say like I'll go broad. I'll say like there's 3 broad categories that I would recommend that students read about. So, anything that has to do with like just kind of personal development and growth, and maybe / leadership development. I think that, you're in med school, you're so focused on your studies and, learning how to talk to patients and things like that. But people are going to see you as a leader, even as a med student, So I think taking some time for personal development and leadership development would be really, really important. I also think that, especially in the context of our conversation today, just, you can't go through life with your blind spots or not trying to address them. And so some book around unconscious bias or learning about, other people or being a better person with other people, that kind of thing. And then the last one, I would say, last big category would be something around wellness. So figuring out how to care for yourself. So I have a colleague who recently wrote an article. Her name's Dr. Kathy Pipus on Caring for You, Caring for Me earlier this year in 2020, for physicians and thinking about self-care. She also wrote a book called The Doctor's Dozen. So I think that's a great book at some point, not as like, you don't necessarily have to read it cover to cover like the first time, but it has several principles, 12 as a matter of fact, on how you can be well personally. Related to the implicit bias or unconscious bias, there's tons of stuff out there. A lot of people like the book Blind Spots. And so maybe that's one. If you're specifically trying to think about race and understanding racial issues, especially as it relates to African Americans, maybe the book, The New Jim Crow Laws by Michelle Alexander. That's another one. And then the one, if I had to say, look at it, you've got that in your repertoire there. Super cool. And the other one that I would say, like from a leadership standpoint, I've read several things. I've read like stuff by John Maxwell and just different people. But the one that stuck with me over time that I feel like it's easy and a bit comprehensive is the 7 Habits of Highly Effective People by Stephen Covey. And I just like that book because it teaches you principles of like, seek first to understand, then to be understood, right? And that's something we definitely have to do in medicine. Or, coming out of a situation with a win-win. That's where people get that win-win concept from, and not win-lose or lose-lose or those kinds of things. And just so many principles that I think you can take with you during your entire life about growth and time management and moving from a place of dependence and dependent relationships to really independence, and then maturing to interdependent relationships. So I would say if I had to just say one book, that's the one I would say.
All right. Thank you so much for that.
You're welcome.
Dr. Brown Speights. I know that as medical students, we can get accustomed to really only reading textbooks. And in order to be well-rounded physicians, we definitely should delve outside that realm. Mm-hmm. So last kind of get to know you question. COVID's kind of affected us all in different ways. Some people just choose to kind of shut themselves inside their apartment or home and kind of not do anything. But what about you? Any new interests or unique hobbies that you've picked up since COVID?
Yeah, that's a great question. So 2 things. So the beginning of COVID, I was getting adjusted like everybody else. I started working super duper hard. My hours increased dramatically. And I wouldn't say that I think it's a little bit better now that we've gotten adjusted to some things, but I really had to take a step back and say, whoa, what in the world's going on? Like I'm working way, way, way too many hours. And then I also noticed that I was giving myself permission to eat things that I didn't normally eat like every single day. So I don't have to have a lot of sweets or anything like that in my diet. And I have a pretty near vegetarian, like more Mediterranean diet, but I consider myself a pescatarian. So I think I have a generally healthy diet, but hey, chocolate covered almonds are my weakness. And I'm like, I gotta have chocolate covered almonds. So I gave myself permission to do that. And I'm like, after about a month of that, I'm like, wait a second, you're going to gain a whole bunch of weight or, mess up your, lipid profile or whatever, So I just had to readjust, I took a moment and I got invited to join a run club. And I'm like, ooh, that sounds really interesting. And so that's my new thing. I joined a run club and I don't run all the time. So the first month I joined, the challenge was like super duper hard. But I ended up doing 100 miles. So that was pretty cool. Whoa. And yeah, but I don't run the whole time. I run walk. So now I'm still run walking and it's pretty fun. I've changed my goals just to meet like something that's sustainable and enjoyable long term. And I also started gardening. Yay.
Oh, wow.
Yes, that's super duper cool. I grew up with the father who gardened all the time. So grew up with fresh veggies and fruit and stuff like that sometimes. And I would dabble here and there over time, like I do an herb garden or maybe tomatoes or something like that. But I actually planted a garden this season and harvested my first sweet potatoes in the last week. Yeah, the 1st of October, the first week of October. So that's been super cool. So I have sweet potatoes that were very successful. I tried to grow carrots. They turned into these little stringly things. I was able to grow. I still have okra growing now, which is super cool. So it's really interesting to watch them grow. Earlier this week, I saw a praying mantis in the garden. So that was kind of cool just to learn about a praying mantis. So there's so many, and I feel like there's so many life lessons in gardening as well. So it's been pretty cool to seed, cultivate the soil, watch it grow. I started composting a little bit as well for my next, for my fall garden. So that's my new thing and I love it.
Wow. So Richard, if we were to wake up at 4:45, we could start doing half of these things also. That's
I would love to get into gardening.
That's amazing. Yeah. And honestly, moving 100 miles, any way you can move 100 miles, that's impressive.
Well, I will say
I guess unless it's a car.
Right. Exactly.
I mean, you're not driving 100 miles.
Exactly. Just my feet are moving. Yeah. And it actually allows my brain to relax. So that's good. Mm-hmm.
So just to kind of change up the tone a little bit and delving into our main conversation today, which is the interplay between race, racism, and health. Why don't we just start off with a simple question? How would you define race?
So that's good. You said a simple question and it's not so simple. And then it is simple, So I would say that race is a social construct, and that's sort of the language that I've been using. And it's something that, is so important for us to sort of figure out that it has so many social implications, if you will, And I think, I remember looking at a video where students, younger people were, they were tasked to say, okay, out of this group, this really diverse group, who do you think your genes are going to be the most like? You've got this really light, fair-skinned kid with curly red hair, and then you've got someone with darker pigmented skin with, kinkier hair, and just different types of people, like a whole group of different people. It's very interesting to see how people thought they would be more genetically like who they were phenotypically more like, and more genetically different than the people that they were phenotypically different from. And, it's quite the opposite. We are more genetically alike underneath the skin than we are different. And there's more variation within an individual than there are, between different individuals and different races, if you will. So, really understanding that race is a social construct, I think is so important as we think about the work that we do and how to help people be healthy and how to treat people with honor and respect.
Great. So, and, going off of that, of race being a social construct, what is the relationship that we know about between race and health, this social construct and health of people in the United States?
Yeah. So it's a complex interplay, so there are certain things that we see genetically associated with race and ethnicities. And we could probably use race, ethnicity as sort of race as a broad term to sort of include ethnicities, if you will, in this conversation. But you see certain things kind of run in families, if you will, or run in certain racial groups, or certain things are more common in racial groups. And what you'll see oftentimes is actually disparities as it relates to different things in racial groups, right? So, in the African American population specifically, you'll see a lot of data around the rates of hypertension or the rates of deaths related to this or poor outcomes related to this are 2 to 3 times the non-Black race, or 2 to 3 times that compared to the white race. And that even brings up a conversation around, how is the white race the race that people are sort of the measure that people are comparing races to. But I think some of those things happen or they look like they're appearing to run along genetic lines because of systemic racism, and how racism gets under your skin. So really over the course of life, your environment, your social environment, your socioeconomic status, what we call the social determinants of health, the places where people live, work, move, breathe, and play and worship, those places impact your health. They impact, your access to good, nutritious food. They impact your access to stressors. They impact your access to good education and good housing. And we know that education and housing are super important as it relates to wealth building and wealth and income and being able to get good jobs. And, that turns back into, being able to get access to good, nutritious food and, even housing, like where people live, like if there's poor investment or, redlining or disinvestment in communities of color, that has an impact, in so many different levels, like food, businesses, educational things, all of those things are tied to our health. And that's how things get under the skin. They show up as, these huge disparities over time. And
Right,
they show up in a way that does become a genetic issue. Like we talk about, there's studies that talk about for Africans or people of African descent, how African Americans have worsening health as it relates to, or more likely to have hypertension, for instance,
right,
compared to people that they may have genetic roots, right, come from West Africa. And, you see this migration problem or this change in health the longer that people live here in the United States. And you begin to look at these studies over time and say, hey, what's the denominator? What's the common factor here that's contributing to this? Of course, it probably has to do with, maybe like socioeconomic things, right? But in addition, race is a huge issue as it relates to that. And because you see inequities despite race, and you see inequities that are worsened because of, or despite, you see inequities based on lower socioeconomic status, but you see them compounded by race, and it's this racism, the stress over time of being a person of color in America that really adversely impacts people's health.
All right. Thank you so much for sharing, Dr. Brown Speights. And I think that that's definitely an important conversation to be had. I know when I first discovered that hypertension is more prevalent in African Americans here than people of African descent, I thought that was really interesting. And I also wondered what the common denominator was. And speaking of having these conversations, I think that one of the first ways to kind of start dealing with health inequities and social determinants of health is to have conversations with everyone around you. But that might be difficult sometimes, especially from a medical student point of view. So in terms of starting conversations, how would you recommend that medical students go about starting conversations with either colleagues or maybe even superiors like attendings or senior residents about social issues or the racial disparities that we see today?
Yeah. That's such a challenging thing because it can be a very intimidating conversation to have. And especially as a student, really thinking about the different, places of power and, people feeling comfortable sharing like how they feel and those types of things. But I think if you start, and this may not sound super popular, but start from a place of love. I mean, it's something that we get taught like when we're a kid, to love people, love your neighbor as yourself, So starting with a place of love and intentionally, I think that that's really, really important. And trying to start from a place of shared values as well. So if there's some place that you can find common ground or some common value that you can use to introduce the conversation, I think that that's really important. I also think that it takes a lot of, it takes intentionality, like I mentioned before, but also courage, and perhaps even talking to someone else about it. Like when you go at these things alone, it makes it a lot more difficult. But if you can have some kind of a champion with you or an advocate or somebody who's saying, I want to be in this with you, or I want to have this kind of conversation with you, I think it's important. And sometimes you just have to have a crucial conversation. I think, sometimes we dance around the issues, but I think if you want to address it and you want people to understand what you're trying to address, you do have to state the issue. You have to state what you're talking about. One thing that I learned from Kamara Jones, and I really like the way that she talks about racism. She describes it as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength just really of our entire society. And she describes it in those three levels, right? Institutionalized, personally mediated, and internalized. And really, I think if we're going to make a huge difference, we have to get at the institutional things. So when you think of it from an institutional standpoint, you're thinking of systems, right? You're thinking about how can I change systems? How can I change structures? How can I change policies, like how we do things? But you can still deal with it from a personally mediated standpoint, right? From that interpersonal level or that individual level. And I think that's what you're talking about as far as that starting place, which is really just starting with a conversation. I watched this YouTube TED Talk on, it was basically about crucial conversations. And this woman was telling her story and decided to just go out of the box and invite people for a cup of coffee. And her cup of coffee invitation was kind. It was a loving gesture, if you will. It was a gesture of opening up her space to receive somebody in. And I think she started with that seek first to understand, then to be understood principle, and a value-based principle not compromising what she believed, but being open to having a dialogue with someone that was different from her. And by taking that courage and taking that step, I think that opened the door for some of these really crucial conversations, if you will, to take place. And there's a whole protocol, if you will, for crucial conversations. But I think that this is just sort of a nugget to say, you know what, be intentional, have a desire to operate from a place of love, a place of value, try to find shared values, shared common space, have a safe space. That's really important as well. And then open up the dialogue. And I don't want to neglect to talk about safe spaces, because sometimes you don't feel like you're in a safe space. And if you don't feel like you're in a safe space, then that's when you definitely want to have another person join in with you. Or people. I mean, you don't want to gang up on someone. It's just more of a, having an advocate, if you will.
That was fantastic. All of this is so helpful. And I want to kind of pinpoint on one thing you were talking about of that interpersonal connection that you can have, especially as we are moving towards being clinicians and heading into residency, where we will be interacting one-on-one with a lot of patients or with the patient's family. And Kamara Jones also talks about this myth of meritocracy, of this kind of obsession with blame and pull yourself up by your bootstraps in American medicine and also just in American society. And I was just hoping to just read one little part and get kind of a comment from you, if that's okay. She says, I give you that most people who have made it in this country have worked hard. But even as we acknowledge that most people who have made it have worked hard, we must also recognize that there are many, many other people who are working just as hard or harder who will never make it because of an uneven playing field.
Yeah, that's so powerful. I mean, it's powerful. It saddens me a little bit just to hear that, because I think especially, in 2020, I've lived a long time now. I'm not in the middle of my life yet, but I'm certainly closer to that than I am at the beginning, and to think that we're still dealing with unfair playing fields really gets to the heart of what helps me keep doing this work, And even when I think about patients, and sometimes I'll see them and they're working really hard to do well, right? They're working multiple jobs. They have, different people trying to help them out. And, you don't see them starting from the same place, right? If you, we talked about with the social determinants of health, or, the places where people live, or even we can call it the social determinants of equity. If people aren't starting from a resourced place, and it turns into actually a legacy of lack of resources, right? Chronic disinvestment. So it's not just one episode or one thing that happens, but over time, really not investing in people and communities really puts them at a disadvantage, so that no matter how hard you're working, you're constantly trying to get above ground and above where you need to be. This economic injustice and disparities is really huge. And when you think about the wealth gap and how, the wealth gap, it's cents on the dollar compared, for African Americans and for Hispanics compared to white Americans. That shouldn't be the case. That gap should not be there. And what happens is, if you have a family where, your father or your mother passes land to you, or they pass a home to you, you're already in a whole new place, versus if you have a place where, you didn't have the opportunity from years back. Someone took your land, they stole your land, they ran you off the land, they forced you. There's been so much migration of people from the South to the North and different places. Even I have stories that I learned about in my own personal history, family history, of how land was let go of because of discrimination, racism, and not just the discrimination, the word, okay, I'm going to say something bad about you, but the threat for life, and, when you think about the harm of disparities and racism and things like that in America, it's death. It's not it's not just, a poor feeling or, hurt feelings or something like that. You're actually looking at death. People are dying more. They're having shorter lifespans, things like that. So, absolutely, not being able to start from a fair playing field where you have land that you can pass on to a child, and they can pass that on to their child, really makes a difference. People, and it's not with their disparities as it relates to socioeconomic status as well. And I think racism just compounds it, certainly. But when people get unfair treatment, And then they also don't have the reserves that they need. I mean, think about it. If someone is unfairly let go from a job and they live paycheck to paycheck, imagine what that does. Like all of a sudden they've gone from having health insurance and having a home and having all the things that they need, to the next month of like being in a very desperate situation. And if you have children involved in that as well, and now you're talking about childhood poverty, and it just is kind of this chronic thing that can happen over time and produce a legacy and a long-term effect, if you will, of racism. So when people say, oh, slavery's done with, it's gone, I don't know what people are talking about, there's a lot of legacy that people are still living out generations to come. And it's not that far from us,
Right.
I thought about my grandmother who just passed earlier this year. God bless, I'm just so blessed to have had her in our lives for almost 100 years. She could tell you stories. I mean, she was alive during some of this stuff, so it's not that far removed from current day.
Yeah. I mean, that, and it does, it brings light to why some of the research is so true, where even stratifying across socioeconomic status, at the same socioeconomic status, there are still health disparities between races because of this lived experience and long history of systemic racism. That makes a lot of sense.
Yeah. Well, it goes back to the conversation we had earlier about, genetics and race and health and things like that, how racism gets under your skin. Because what happens, and there's just theories related to stress and the changes that happen. I mean, this is also seen in the literature related to adverse childhood events, and there's lots of data about these epigenetic changes, if you will, stress over time, stress early in life, those types of things really impact your health. They can shorten your telomeres, they can they can cause epigenetic changes that even could get passed on. My area of interest is infant mortality. And so there's some studies that show even for women that, have achieved higher education, they're more successful, they're seeing the success and doing well socioeconomically, they're still more likely to have adverse outcomes, as it relates to infant mortality or maternal mortality. And then also looking at women who had premature children, they're more likely, their daughters are more likely to have premature babies as well. So just, you begin to see like how racism not only affects that person, but generations after that person. I also wanted to mention something too, and you were asking about genetics, because we were talking about race and how race is a social construct. There are genetic things that do tend to be more common in certain races. So we're not saying that there's no biological components, because there's certain genes or, certain things like thalassemias or, sickle cell anemia, or even the gene that's related to poor outcomes as it relates to renal disease and hypertension that is more common in certain races. So I just wanted to kind of bring that forward to say that we're not saying that there's no genetic contribution to disease. That's not it at all. There's that biopsychosocial, kind of socioecologic, biomedical model, all mixed together, really theory that helps us explain race and health.
All right. Thank you for sharing that, Dr. Brown Speights. And we've definitely touched on a lot of different topics regarding racial disparities. And I kind of wanted to delve a little bit into your day-to-day and maybe get a little bit more personal and ask you, have you seen the effects firsthand of racial disparities in your day-to-day work as a clinician? And can you give any examples or anecdotes by any chance?
Yeah, I've seen it in different ways. And I think, in 2002, the unequal treatment report came out and really highlighted the impact of patient-provider communication, that will really highlighted the impact of the patient-doctor relationship, right? The patient-physician relationship on health, and how implicit bias within the provider can impact the outcomes of patients that they care for. So I've had patients that have come to me, and as a clinician, I would say I'm humble. Like I'm not saying that I'm the I have all the answers or anything like that. But just sharing my experience as you asked. And so I've had patients that come to me that have been, seen by other providers that didn't understand, or that ignored them, or, didn't listen to the signs, or didn't listen to things that they were concerned about. And that changed their outcomes. Either they had a poor outcome, they lost a child, or they had a child prematurely, or, they had some poor outcome as it relates to cardiovascular disease or cardiovascular health. So I've seen it that way. I've also seen it where it impacts health literacy, right? So patients just have no clue about certain things, and the provider not that they're aware, I wasn't in that space, didn't tell them about that. And when you have people that are dealing with health literacy issues, you really have to take the time to understand where they're coming from, try to communicate in a way that's culturally responsive, so that you can provide the best amount of care. So I've seen it in those circumstances. Also, some of the research that I've done in the sense of community engagement around Black infant mortality, I was able to really glean a lot from, women who either had experienced Black infant mortality or they knew somebody who had experienced it. And they shared a lot about, things that they experienced in the healthcare system and lack of access. And there's one quote that sticks with me is that I have access, but there's still no access. So of course, lack of insurance and lack of health insurance is a huge thing, right? People that don't have health insurance and have access to care, it's hard for them to be healthy. It's just a matter of fact. But even people with insurance, either insurance or underinsured, they're underinsured, complain that they still don't have access because of how people treat them when they call, when they come into the office, feeling discriminated against, feeling like they're not heard, feeling like people don't understand them, feeling like people are judging them. And you can imagine our patient-doctor relationship or our patient-physician relationship is a therapeutic relationship, right? It's supposed to help people heal. Like that's why we went to medicine, because we care about people. We want them to be healthy and whole. And I think patients come into that relationship generally thinking the same thing. But if there's this lack of trust or mistrust or mistreatment in that relationship, then it really limits and hinders the patient's ability to do well.
Fantastic. Thanks for sharing that about kind of now getting into the healthcare setting. And so we've gone from, some societal inequities to, healthcare inequities, which we know can both be really important determinants of health. And I guess our next question is just where, for either way, you've kind of touched on some of the societal changes that we need to see, but either way, from society or healthcare, where do you see the best place for starting intervention?
Yeah, we touched on that a little bit. I would say get in where you can get in, or get in where you fit in. I hope that's not too cliche or too catchy, but really just starting, like being intentional and making a decision to start. So, you could start at the individual level, you can start at the systemic level. Like either of those places are good places to start. And the individual level, we talked about some of the tools, like that's that one-on-one that you can do. The thing we didn't talk about from an individual level is your personal work, right? Like if you need to understand, like, and we talked about it a little bit, but understanding your own bias. Everybody has biases, right? So understanding that implicit bias, the unconscious bias, and even the conscious biases, like challenge yourself, confront yourself, look in the mirror, talk to people that you trust, have them, give you feedback. Make sure you're not spending time with just your same. Take a risk. Go be curious about other cultures. Be curious about other people. Volunteer to work with people in diverse groups, so that you can understand and kind of develop this place of empathy. I think that that's a really good starting point as an individual. And I would say, cultivating empathy is the way that I would categorize that. And then, from a systemic standpoint, there's lots of advocacy that students, providers alike can get involved in. On a local level. And then there's, of course, national advocacy and policy work that people can do. So I really think that just exploring your areas of interest, the sense of like where you'd like to spend some time working would be, an easy first step. And there's lots of organizations like, I'm a family physician. So there's the American Academy of Family Physicians. There's the Society of Teachers of Family Medicine. There are groups that do advocacy work, and you can connect with them to understand, okay, how can I get involved in some of the work that you're doing? There's so many other groups, that are doing work already. So you don't have to feel intimidated. You can, join in with somebody else from an advocacy standpoint. If you're in a system like, maybe a health system or your own personal clinic, you guys are going to be in residency soon, and then you're going to have your in your practices and, all kinds of different practices, right? Academics or private practice or, hospital-based practice, whatever it is. that's an opportunity there too, to think about what are your policies and procedures? What am I doing about diversity and inclusion? What am I doing in diversity and inclusion excellence? Or what am I doing, or what are we doing to make sure that our patients feel included and diverse? What are we doing to address social determinants of health? What are we doing to engage the community? What are we doing to address workforce development and making sure that we provide spaces for people who look like the people that we're serving, to make it a more culturally responsive place? Are we doing, culturally responsive training? Are we doing implicit bias training? Are we making sure that we're adhering to class standards and standards of care and quality measures? Are we measuring quality things? So those are all policy related things or systems related things that can really impact the system of care, can impact health care delivery. So I think we can, like I said, take the individual and do the individual work, but then there's also systems work that you can get into from all the different levels, whether it's like local advocacy and just systems and policy, like informal policy things like within your practice or what you do on a regular basis, or all the way up to government changing laws and things like that.
Yeah. I mean, and I think hearing you talk about this is one of the ways that people will start feeling more comfortable, getting involved and saying, no, I really do want to be part of dismantling some of this racist structure. So we can cut this out, but I have a specific question follow-up before we kind of wrap everything up, which is about in our institutions that we become a part of, it's likely that we'll still see race-based medicine with a different category for GFR, for example, for African Americans. That's just one kind of common example. But how do you suggest we approach that? And what do you think that that's a major concern of something that we should be working to kind of break down?
Yeah. That's an excellent question. And race-based medicine is a whole other category. Like you could probably do an entire session just on race-based medicine. There's so much to learn there. And it's not complex, but I think you have to think about the complexities that can be involved in that. Like I said before, there's certain genetic things that are a part of a racial history for someone, right? You do the family history so that you can figure out some of the things that run in the family, like whether it's breast cancer or, whatever the blank is, right? So I think we have to just keep that in mind. But then bigger than that, when you're talking about some of the ways that we designed formulas or some of the ways that we decided to assess, peak flow monitoring for people with asthma, or, there's so many examples that we could talk about related to race-based medicine. I think the best thing to do is to get the evidence, right? We're scientific people, we're clinicians, we're critical thinkers. Get the evidence, pull up the studies. What do the studies show? Do studies support, this kind of use of race-based medicine? And, I was thinking about our conversation today, and when I am very interested in international medicine and global health, global work. And one of the trips that I took when I was before I became a faculty here at the College of Medicine, I went to Peru with a group of folks, and I really enjoyed that experience. It's a very community engaged experience and long-term planning. So it's not like the, just coming in and make yourself feel good and do a little bit here and there. It's just a long-term sustainable collaboration with the people that were there. And in one of our talks, we were on the beach near the border of Ecuador, and just kind of sharing. And our leader was trying to inspire us and not to be overwhelmed, and really just how do you do this work and how do you approach it. And they talked about all these starfish. You might have heard the story before. They wash up onto the shore, and the person's like kind of the mentee, if you will, is saying to the mentor, like, how in the world am I going to, handle putting them back into the ocean, right? Because if they're just there, they'll die. And they said, one starfish at a time. And that sticks with me in so many areas, whether it's, any of the work that we do, but also in the approach to the work, right? You're saying, gosh, how could we overcome, some of these long legacy of race-based medicine or discrimination and racism and things that are hurting people, one step at a time. You can't do it all at once, and you'll get overwhelmed, you'll get discouraged. But if you know what, I'm making a difference. Like what I do makes a difference. My positive change makes a difference. You start with you, then you get a friend, and they get a friend, and they get a friend. Before you know it, you've got this grassroots movement, or you've got this non-grassroots movement, right? That's really changing the system. So I think, just being intentional, I keep saying that over and over, is a really important part of this. And specifically related to race-based medicine is gathering the evidence.
Thank you, Dr. Brown.
Fantastic. Thanks.
And I think it's so important that we're having this discussion on race-based medicine, because I think if I were to go about my medical education without having conversations like this, I would think that a white kidney and a black kidney are genetically different. And it's interesting to see that a field like medicine that's so based on science can have racial bias and implications behind it. So the next question that I have for you is that with all the things going on in the current political environment, the current social environment, I myself find it hard to really stay optimistic and to see that there's an end in sight. And so I kind of want to see how you approach a lot of these issues with your sense of optimism, and if you have any advice for potential change makers to keep themselves motivated and to continue furthering their cause.
Yeah, that is such an important thing. And I kind of alluded to it before, but I would say, don't go at it alone. You have to have people you have to either have people that are your tribe, if you will. People say that sometimes, or just people that think like you, or that you can connect to, or that have similar values that you can talk with. That could be a friend, or somebody that's in your class or something like that. But it doesn't have to be. Like if you don't find that place, you can connect with somebody, but you just want to connect with people that are also trying to do the same thing. I think that's super important. I recently had a conversation with someone that I actually consider, she's a colleague, but I actually consider her a mentor. And it's not a formal relationship, but I definitely am inspired by the work that she does. And she's been doing health disparities work for a while now, established researcher in our area. And, saying, I was just kind of like, oh man, like we've been working on this so long, and, the numbers seem to be the same, and blah, 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 all this stuff. And she's saying, don't get discouraged, because your work is making a difference. The work that you do, the work that we do, the work that everybody's doing is making a difference. You may not see the numbers change like nationally all at once, but you'll see micro changes, right? You'll see changes in your individual community, or you will see changes that are national. So I'd be remiss without mentioning a study that myself, Dr. George Rust, Dr. Samantha Goldfarb, Dr. Les Beich, and I'm trying to think if we had one other person, Dr. Bob Levine, on a paper that we published in the American Journal of Public Health related to state levels of change as it relates to Black infant mortality. And really the message at the end of the day, and the message that I'd like to leave you all with, is that inequities are not inevitable. There's something we can do about it. There's a change. So when you see these glimmers of hope, where you see communities, so what we did was we looked at different states across the United States that met the inclusion criteria, and showed that 13 states within the United States were trending towards closing the gap as it relates to infant mortality. That's huge. And there's been other studies that have shown similar kinds of things as it relates to colorectal cancer and other areas of disparities. And I think that message of hope is really important in the work that we're doing, that there's a change, there's differences happening. And this gets back to my point earlier. Hey, get the evidence, because the evidence is out there. You may not see it, on every single day in every single way, but it's there. And that hope allows you to move to the next step and to the next step, and you can be the change that you want to see in the world, right? You can contribute to the process of that happening and closing the gaps and really eliminating disparities. The other thing that it's really, really, really important is self-care and self-compassion. Because we are like type A people and super loving, for the most part, we care about other people. And sometimes we care about other people to the deficit of our own care, And so when you ask me like my tricks of the trade, or, what do I do all the time? I got to put that first, I got to put, my prayer and time with God and, exercise, my body. I got to put that first, in order to be able to continue to be sustainable in this work. You got to sleep, you have to eat nutritious food, all the stuff that we tell our patients, that's what we have to do. So I just want to make sure that I highlight that self-care is really important as well.
I can think of no better way to end our interview. Thank you so much, Dr. Brown Speights. We've learned, the two of us have learned a lot from you, but also all of the students at the College of Medicine have definitely learned a lot from you. So thank you for this.
No worries. Thanks for inviting me. I really enjoyed speaking with you all today.
Thank you so much.
Thank you for joining us on our inaugural episode of Beyond the Diagnosis. On behalf of all members of FSU Gold Humanism Honor Society, we hope that this was an interesting and empowering session. Please stay tuned for our next episode. Until next time, I'm Edward Cordy.
And I'm Richard Wu, and this has been Beyond the Diagnosis.